You're working in the garage or clearing out the yard, and suddenly you slip and catch your hand on a jagged piece of metal. The immediate anxiety sets in. Do you just wash this out, or do you need to rush to a clinic right now? For decades, people have pointed the finger directly at visible rust. But rust itself doesn't cause tetanus. The real danger is bacterial spores that live silently in everyday soil, dust, and dirt. Figuring out if you need a shot isn't a guessing game based on how the metal looked. It is a strict two-variable medical equation. The first variable is the wound itself. You have to objectively assess its severity, depth, and exactly how much contamination got into the tissue. The second variable is the absolute certainty of your lifetime vaccination history. Treating a potential tetanus exposure comes down to taking the exact physical reality of your injury and running it against the recorded timeline of your past medical care. Once a doctor evaluates your wound and your history, they have two distinct clinical tools at their disposal. The first tool is the tetanus vaccine. You might hear it called the tetanus toxoid, or see it written as TD or Tdap. Those all refer to the exact same injection. This vaccine provides active immunity. It doesn't fight off an infection today. Instead, it trains your body to build its own future defenses over time. The second tool is tetanus immune globulin, universally referred to in clinics as TIG. TIG provides passive immunity. It is an immediate emergency dose of imported antibodies that neutralizes the tetanus toxin the second it enters your system. This table illustrates the functional difference between the two interventions. The vaccine, on the left, guarantees active future immunity. TIG, on the right, delivers immediate passive protection. The entire protocol hinges on one biological trade-off: deciding whether your body has the luxury of time to build its own defenses, or if your wound requires an immediate external rescue. This flowchart maps the medical protocol, starting with a patient fully vaccinated, meaning at least 3 documented doses. For a clean, minor wound, the clinical path is straightforward. A booster is only required if your last dose was over 10 years ago. TIG is unnecessary. If you keep accurate personal records, this specific scenario saves you the time, cost, and stress of an urgent care visit. You can safely clean the wound at home and move on. But the equation shifts if we apply that exact same vaccinated history to a dirty, contaminated, or deep puncture wound. In this scenario, a booster is now required if your last dose was 5 or more years ago. TIG is still not needed. The protocol intentionally cuts the safe window in half, dropping it from 10 years down to 5. A severe wound pushes a cybacterial load into the tissue. To handle that influx safely without the emergency backup of TIG, your active immune response needs to be incredibly recent and incredibly sharp. For the fully vaccinated patient, the severity of the injury dictates exactly how fresh your immunity needs to be to avoid a trip to the hospital. The protocol changes drastically for patients with missing medical records or fewer than 3 lifetime doses. Paired with a clean, minor wound, the clinical response is immediate. This scenario demands the vaccine immediately, regardless of when they assume their last shot was. Because the wound is clean, the risk of rapid infection is low enough that we can skip the immediate passive antibodies of TIG. But the lack of verified history means doctors must kickstart the body's active immunity right now. The final, most severe path evaluates a dirty or contaminated wound, combined with an unknown medical history. This is the maximum clinical outcome. The patient requires both the tetanus vaccine and the TIG immediately. This dual-shot approach blankets the body in physiological protection. The TIG disarms the immediate threat circulating in the blood, while the vaccine simultaneously builds up long-term defenses. Practically, this scenario carries a heavy cost. It mandates an unavoidable, immediate trip to an emergency room or urgent care clinic to receive 2 separate injections. Lacking clear medical records drastically escalates the required intervention. It shifts your options away from wait and see and straight into aggressive medical treatment. Medical learners and first responders don't carry that flowchart in their pockets. They memorize a simple rule to instantly identify the highest risk scenarios in the field. Dirty plus doubt equals double. Dirty covers any wound involving soil, rust, feces, or heavy physical contamination that pushes deep into the skin. Doubt means possessing any uncertainty whatsoever about having received your 3 foundational tetanus shots. And double is the mandatory clinical action. It requires a medical professional to administer both the passive TIG and the active tetanus vaccine. If your injury hits these two specific triggers, there is zero room for hesitation. You belong in a clinic, getting treated right away. For the pragmatic patient, the goal is to avoid the double scenario entirely before the injury ever occurs. There is massive preventative value in taking control of your personal medical records and strictly adhering to a 10-year booster schedule. By simply tracking your dates, you turn the vast majority of future scrapes, minor cuts, and clean injuries into simple non-issues that require zero medical visits. But when a crisis does happen, never guess or assume a timeline if you are truly unsure of your last shot. The minor inconvenience of an urgent care visit to confirm your immunity will always outweigh the devastating, life-threatening risks of an active tetanus infection.